We all know transcranial magnetic stimulation, or TMS, can be a game changer for depression. But its success really boils down to one crucial question. Where exactly do you aim the coil? Well, today, we're going to dive deep into a major network meta-analysis that did just that. It put the leading targeting methods head-to-head to see which one really comes out on top. And just so you know where we're getting our information, this entire explainer is based on a really robust review article. It was published in the Journal of Affect Disorders, which, as you probably know, is a top-tier journal in the field. So you can be sure that everything we're about to cover is built on a really solid evidence-based foundation. All right, so here's our game plan. First, we'll talk about why precision in TMS is such a big deal. Then, we'll introduce the 3 main targeting methods that are being compared. After that, we'll look at the study itself, this network meta-analysis, before jumping into the really juicy stuff, the results. We'll look at how effective each method is, but also at the trade-offs. And finally, we'll wrap it all up with the key takeaways. So, major depressive disorder, it can be absolutely debilitating. And TMS is, without a doubt, a key non-invasive treatment in our toolkit. But here's the thing. Its effectiveness isn't always a sure bet. And that missing piece of the puzzle? More often than not, it all comes down to one single critical factor: precision. And that brings us right to the heart of the matter. For TMS to work, where exactly do you aim? The standard protocol, as we know, is to target the left dorsolateral prefrontal cortex. But finding that exact spot on someone's head, well, that's a huge challenge. Different clinics use totally different methods to locate it, which is exactly what this study set out to investigate. They wanted to find out once and for all which method is actually the best. Okay, so let's meet the contenders. The study focuses on the 3 main ways that are used in clinics right now to pinpoint that stimulation site on a patient's head. Now, these methods really fall into 2 big camps. On one side, you have the scalp-based methods. These are great because they're quick and don't need a lot of expensive gear. The downside, they rely on just measuring the outside of the head, so they're a bit indirect and, less precise. On the other side, you've got the cortex-based methods. These are super precise because they use neuroimaging, like an MRI, to see the person's actual brain. But as you can imagine, that requires some pricey equipment and is a lot more complex. So, digging into the specifics, there are 3 methods on trial here. First is the classic 5-centimeter method. That's a scalp-based one. Then there's the F3 method, which borrows its location from the standard EEG electrode system. And finally, we have the neuronavigational method. This is the cortex-based approach that uses a patient's individual MRI scan for super precise targeting. So, you might be wondering, how can you even compare 3 different methods when they haven't all been tested against each other in a single trial? Well, that's where this study gets really clever. The researchers used a super powerful statistical approach called a network meta-analysis to pull together all the available evidence. So, what is a network meta-analysis? Well, think of it this way. A normal meta-analysis can only compare 2 things at a time, say A versus B. But a network meta-analysis is much more sophisticated. It can combine data from all sorts of different studies, like ones that compare A to a placebo, B to a placebo, and maybe A to B. And it puts all that information together to rank the effectiveness of all 3 methods at the same time. It's pretty powerful stuff. And the sheer scale of this analysis is what really gives its findings so much weight. We're talking about data from 63 different randomized controlled trials. That's a grand total of 3,080 participants. When you have a dataset that massive, you can be pretty confident that the conclusions are statistically solid. All right, let's get to the results. This is the part we've all been waiting for. We'll start with the main event, antidepressant efficacy. The big question is, how well did each of these targeting methods actually do when it came to reducing symptoms of depression? Okay, so this table right here summarizes all those head-to-head comparisons. We're going to focus on the numbers you see in the lower triangle. Those are the key results from the network meta-analysis. And what they represent is the standardized mean difference between the different treatments. So, the first big takeaway is this. Both the high-tech neuronavigational method and the simpler 5-centimeter method were significantly better at reducing depression symptoms than a sham or placebo treatment. That's huge. Interestingly, the F3 method didn't actually show a statistically significant advantage over the sham treatment in this particular analysis. Let's put some numbers on that. The neuronavigational method had a standardized mean difference of 1.19 compared to the sham treatment. For those of you who track these things, you know that's a large and clinically very meaningful effect size. But here's where it gets really surprising. Let's see how the simpler method stacked up. And this is pretty wild. The 5-centimeter method performed almost identically. It had a standardized mean difference of 1.13 versus sham, which is also a very large effect. In fact, the analysis found no statistically significant difference in how effective these two top methods were when compared to each other. Now, to rank these treatments from best to worst, the study used something called a sucra analysis. It basically just calculates the probability that each method is the most effective one. And as you can see from this chart, neuronavigation just edged out the top spot with a 79.3% probability. But look how close the 5-centimeter method was, right behind it at 73.9%. The F3 method, well, it was a distant third. But efficacy isn't the whole story, is it? For a treatment to be truly successful, patients have to actually stick with it. That's acceptability. And it has to be tolerable, meaning it doesn't cause a ton of side effects. And this is where we start to see some really interesting and important trade-offs. This radar plot is a fantastic way to visualize these trade-offs all at once. It's simple. The further out a method's line goes on one of the axes, the better it did on that particular measure. So you can see right away, look at the neuronavigational method in teal. It's a rock star on efficacy and acceptability, but then, boom, it pulls way back when it comes to tolerability. And this table here just breaks those rankings down with the actual numbers. You can see neuronavigation is number 1 for efficacy and number 1 for acceptability, meaning it had the lowest patient dropout rate. But, and this is a big but, it's ranked dead last for tolerability. That means it was linked to the highest rate of adverse events. And just as you'd expect, the sham treatment had the best tolerability, but of course, the worst efficacy. The authors of the study really hit the nail on the head with this quote. They say that neuronavigational targeting may give you higher efficacy, but its potential to increase adverse events is something that has to be carefully considered and managed. That really sums up the core dilemma, doesn't it? Okay, so let's pull all of this together. After going through all that data, what are the real take-home messages? What should clinicians and researchers be thinking about now? All right, here's the bottom line. First, it's clear that both neuronavigation and the 5cm method are genuinely effective treatments for depression compared to a sham. No question about that. Second, while neuronavigation seems to have a slight edge in efficacy in keeping patients in treatment, it comes at a cost. It also has the lowest tolerability, meaning the most side effects. So what we have is a very clear clinical trade-off. Do you go for maximum precision and efficacy, or do you prioritize the best possible tolerability for your patient? And really, that leads us to the final, critical question that this research leaves us with. It's not so much about which method is best in a vacuum anymore. The real question now is, given these trade-offs, how should clinicians choose the right approach for each individual patient? How do we balance efficacy, cost, and side effects to truly personalize TMS treatment? That's the challenge ahead.